I'm going to follow the same format that Natalie did. We'll go through the knee. We'll look at some normal anatomy and some common pathology, and then we'll do a demonstration scanning our model's knee, and then I'll try and answer any questions that you might have. So I have no disclosures, and the aims of this lecture are to review the relevant anatomy and review the common pathology. And special thanks to my good friends and colleagues, Tony Buffard, Marnix van Holsbeek and David Fessel, for kindly loaning me some of the slides I'm going to show you. So, if we look at ultrasound of the knee, most advanced imaging of the knee is MR, and that's fine. I'm a musculoskeletal radiologist and we do a lot of knee MR, and so we're not going to get up here and say that ultrasound's a better modality than MR, or we should be doing all these cases with ultrasound, where ultrasound is very useful. And these scenarios are settings where the clinician has a specific question, and in particular assessment of quadriceps tendon tear, assessment of patellar tendon tear, evaluation of Baker's cyst, and evaluation of the knee joint effusion and possible aspiration. So they are all common scenarios where ultrasound is an ideal modality. All right. So let's carry on. So these four scenarios. So they're scenarios in which the clinician asks a specific question. All right, now let's look at the normal quadriceps tendon to start with. And this is how we scan the patient in the longitudinal plane. Remember, the quadriceps is an extension of the vastus musculature and also the rectus femoris musculature. It's a very thick and strong tendon coming down, inserting into the superior aspect of the patella and the anterior aspect of the patella, and then continuing as part of the extensor apparatus as the patellar tendon. So this is the normal quadriceps tendon in the longitudinal plane. We see a nice fibrillar pattern. Here's the prefemoral fat. We don't have any fluid in this knee joint. We don't have any fluid in the suprapatellar bursa. Here's the patella here. So that's normal quads tendon and longitudinal. And let's look at it again in another patient. And here it is here, linear fibrillar appearance. It's a very easily identifiable structure. Here's the superior pole of the patella. This is a longitudinal image. And then notice there's a little bit of fluid in what we call the suprapatellar bursa, an extension of the knee joint, and between the quadriceps tendon and the prefemoral fat. Here's distal femoral cortex here. So here's the normal quadriceps tendon, and here it is in transverse. We turn the transducer 90 degrees, and here's the quadriceps tendon in transverse. Here's the distal femur and the prefemoral fat, the packing fat over the distal femur. So if we all just make a mental note of what the normal quads tendon looks like, and one more image. This is more coned in, nice normal hyperechoic fibrillar appearance to the quadriceps tendon inserting on the superior pole of the patella. Here we have such good resolution we can actually see some of the hyaline cartilage of the medial femoral condyle. So that's normal quads, all right, so we just make a mental note of these images. And here's an extended field of view, quadriceps, here's the patella, this is a longitudinal or sagittal image if you like. Here's the quads coming down, here's the patella, and then extending on is the patella tendon to the tibial tuberosity. Now, rupture of the quadriceps tendon is more likely to occur in older patients, and in particular in patients who have systemic disease, including diabetes, chronic renal failure, hypertension, gout. On radiographs, it's important to look at radiographs, and there are clues on the radiograph. Often the patella may be low-lying and there may be bone fragments. So this is a common indication in our practice. Usually a patient presenting to the ER, it's thought clinically there's probably a quadriceps tendon rupture, or it's thought on a radiograph there's probably a quadriceps tendon rupture. It's very easy to bring the patient up from the ER and scan the quadriceps tendon. And this is just a precursor to rupture. This is gross tendinosis in the quadriceps tendon. We lose that nice fibrillar pattern, but the quadriceps tendon still comes down and attaches. So this is gross change in the quadriceps tendon, gross tendinosis, without as yet frank rupture. And here's a case of quadriceps tendon tear. So these are both longitudinal images, and this one's more with an extended field of view. But here's the patella. This is longitudinal or sagittal, if you like. Here's the patella tendon. Here's the quads tendon, and look, it's a little bit bunched up, and there's a gap here between the arrows. So here's the distal stump. There's a little bit of fluid also in the suprapatellar bursa. It's common to have an effusion in the knee joint after quadriceps tendon rupture. Here's a more extended field of view in the same patient. Here's the suprapolar patella just sneaking in here. Here's a little fragment of bone that we see, and we've lost that normal fibrillar appearance of the quadriceps tendon. Notice also we can see the medial femoral condyle here, and actually, because we have fluid in the joint, we can actually see, this is the subchondral bone plate of the medial femoral condyle. Here's some of the hyaline cartilage of the medial femoral condyle. So this is, unquestionably, this is a quadriceps tendon tear, and you can tell your clinical colleagues in the ER that quite confidently. Here's another case, more coned in, a longitudinal section. Here's the suprapolar of the patella just sneaking in. Here's the proximal stump of the quadriceps tendon. Here's the distal stump. We see fluid hemarthrosis between the two stumps. So this is another quadriceps tendon tear. And most times the quadriceps tendon will tear either at or just a little bit above the superior pole of the patella. Here's another case, and we would suspect this on the radiograph. Here's a lateral radiograph of this patient's knee following minor trauma, very minor trauma. Notice there's a large effusion within the knee joint. Notice that the patella tendon is low lying. Not only is it low lying, it's actually angling, slanting slightly. And then there's a lot of indistinctness of the soft tissues anteriorly. So this is very suspicious that there's a quadriceps tendon rupture on the radiograph. And it's very important, as I mentioned before, to interrogate the radiographs on all these patients. Unfortunately, we don't always have radiographs when the patients are sent in from another institution and turn up for an ultrasound of the quadriceps tendon, but most times we do have radiographs. If you have radiographs, you should always look at them carefully. And then here's the same patient with that, from that X-ray. Here's the superior pole of the patella. So this is a longitudinal extended field of view. And notice the appearance looks nothing like the appearance we saw with the normal quadriceps tendon. So there's a tear. The tendon has torn at the superior pole of the patella. There's a big gap here. There's a hemarthrosis. There's actually fluid tracking anteriorly. Sometimes fluid will actually track into the prepatellar bursa. This looks like it's probably going into the prepatellar bursa, although I can't be absolutely certain of that. There's also one or two tiny little bony fragments here, and then again there's a complex effusion in the suprapatellar bursa. Here's the distal femoral cortex. So this is a quadriceps tendon tear. The quadriceps tendon, when it tears, it can tear in variable extent transversely. Often it'll tear completely just all the way across. Sometimes only transversely a small amount of it tears. The general rule is if more than 50% of the quadriceps tendon is torn in the transverse plane, that the surgeon will repair the tendon. Sometimes even less than that, the surgeon will repair the tendon. Most tears we see go to surgical repair. Okay, so let's just move on a little bit lower now. We want to look at the normal patella tendon. So we just in the longitudinal plane bring the ultrasound transducer a little bit more inferiorly, which we'll look at in the live model demonstration, and this is a normal patellar tendon. So here's patella on my left rather, and then the tibial tuberosity. Here's normal fibrillar appearance to the patellar tendon. Immediately below the patellar tendon is this structure, the anterior knee, which we call Hoffa's fat pad. So this is normal patellar tendon. Another couple of images, including the transverse image. Again, the normal fibrillar appearance, the tibial tuberosity, Hoffa's fat pad. Then we turn transversely on the tendon, and we have this hyperechoic oval structure. Now, rupture of the patellar tendon is more likely to occur in younger patients, particularly children and adolescents, although we do see it in patients with systemic disease. Also, the patellar tendon may on radiograph be hiding, which again reinforces in all these cases, if the patient has radiographs, we want to look at the radiographs carefully before we do the ultrasound examination. In this example, you can see that that normal appearance that we saw a minute ago of the patellar tendon is completely gone. There's no normal looking fibrillar appearance here. Now, what there is there's a bunched up, retracted patellar tendon, which is torn from the inferior margin of the inferior pole of the patella. There's a gap here which measured about 1.5 centimetres, bunched up tendon, tibial tuberosity here. And here's another case, proximal tear of the patellar tendon. So this is a longitudinal image. Here's the inferior pole of the patella. Here's the quadriceps apparatus on the anterior aspect of the patella. Here's the patellar tendon here, retracted, slightly bunched up patellar tendon, and here's hematoma between the two between the two stumps rather of the patellar tendon. Now, most times when the patellar tendon tears, in my experience, it tears either at the inferior pole or within the proximal portion of the tendon. I've only seen the patellar tendon tear distally once, or at the most twice. So most times when the patellar tendon tears, in my experience, it will tear at or near the inferior pole. And then here's another case. This is an extended field of view. This is a longitudinal or sagittal image, if you like. Here's the patella. Here's the tibial tuberosity. And if we look at the lower half to 2/3 of the patellar tendon, it doesn't look too bad, but notice the proximal third to a half. There's two parts here that are bunched up. We've lost that normal fibrillar appearance, and there's a tear of the patellar tendon, not quite at the inferior pole, just a little bit away from the inferior pole. And then here's another case. This is chronic patellar tendon rupture, because remember, sometimes quadriceps tendon tears and patellar tendon tears are missed. They're missed clinically. Sometimes they may even be missed radiologically. Or sometimes what happens is that patients have an injury and then they present late as well. But anyway, here's a chronic patellar tendon rupture, and you can see there's well-formed ossific fragments. Some of these may have come from the inferior pole of the patella. Some of them, I suspect, are post-traumatic ossification in the stump. And here's a longitudinal image, or sagittal image, if you like. Here's a normal quadriceps tendon. This is just dropout or anisotropy. It's a normal quadriceps tendon. Here's the patella, and actually you can see it looks like it's slightly tilted. And then there's several of those bony fragments we see, which we saw on the patient's radiographs. And there's a gap here. So this is chronic patellar tendon rupture, chronic patellar tendon tear. And now let's go on to patellar tendinitis, or so-called jumper's knee. And jumper's knee we see most commonly in young athletes, and in particular patients who play basketball or who are runners, predisposed to this condition, although sometimes you'll see it in other sports as well, football players, etc., but in particular basketball players and runners. And this, we can see here, there's a focal swelling at the inferior pole of the patella, and it tends to occur in the inferior half to 2/3, right? See these more superficial fibers don't look too bad, but there's a triangular hypoechoic area here. It's basically a chronic traction injury where you get repetitive micro-trauma to the attachment of the patellar tendon at the inferior pole, and then you get secondary changes. It can be quite painful, it can be quite disabling. And here's another case, the jumper's knee. Inferior polar patella, this is a longitudinal or sagittal image. We're coned down. So here's the patellar tendon. We've got about the proximal third or so of it. We've coned down onto the patella here. And here you can see there's a regularity of the inferior pole. There's some chronic traction on the inferior pole. And then there's also some hyperechoic areas within the actual tendon itself. And these represent little fragments of bone which may have been avulsed and or small areas of ossification. And then there's this triangular area on the deep, on the inferior half of the patellar tendon. It's hypoechoic, and this is very typical of jumper's knee. And as I say, it can be quite disabling. Here it is in transverse, and in transverse again. So we've coned down. We're just below the inferior pole of the patella. Same patient that we saw on the previous slide. So we've coned down. So here's the superficial or outer half to third of the patellar tendon, which doesn't look too bad. But notice in the deep part of the patellar tendon, involving most of the patellar tendon actually in this patient, there are all these changes. So this is chronic jumper's knee. Now sometimes when it's not as marked or as active as this, you'll see the change in the middle 50% on the deep part of the patellar tendon, or sometimes you see it more in the medial third to half. All right, so now we go on to distal patellar tendinosis, or Synderglassen, to Osgood-Schlatter rather, disease, and this is a chronic traction at the insertion of the patellar tendon on the tibial tuberosity, and this is primarily, I believe, is a clinical diagnosis. It's typically in adolescents or younger patients. They typically have pain at the attachment of the patellar tendon on the tibial tuberosity. It's primarily a clinical diagnosis. We don't image it very much. I'm grateful to Tony Buffard for kindly loaning me these slides. And on radiographs, you see soft tissue swelling over the tibial tuberosity. So that's Osgood-Schlatter. All right, so let's go on now and look at a common clinical reason for ultrasound of the knee. Is there a joint effusion? And we'll go back and we'll look in the suprapatellar bursa. So here's the slide we looked at before, and this is longitudinal. Here's the quadriceps tendon. Here's the superior pole of the patella. This is the prefemoral fat. And see this kind of linear, slightly oval slit here. It's hypoechoic. That's a small amount of fluid in the suprapatellar bursa, and that's pretty much normal. Most people have a little bit of fluid. Sometimes you don't see any fluid, but most people have a little bit of fluid in the bursa. Now here's a little bit, same, different patient obviously, but same plane, longitudinal, sagittal. Here's the quadriceps tendon coming in, inserting on the superior pole of the patella. This is the suprapatellar fat pad here. This is fluid now. This is fluid in the suprapatellar bursa. Here's the prefemoral fat. So we have this hypoechoic fluid. And then here's another case, again, different patient, but the same plane, the longitudinal or sagittal plane. Here's the quadriceps tendon, and we can see that nice hyperechoic fibrillar appearance. We haven't quite gone down enough to include the superior pole of the patella. This is the femoral cortex anteriorly. Here's the prefemoral fat, and how we have a reasonably large sized triangular area in the suprapatellar bursa. It's pretty much uniformly hypoechoic. There's one or two little fronds here and there, but it's pretty much uniformly hypoechoic. So this is fluid, and this will be compressible on ultrasound. This is fluid in the suprapatellar bursa. So that's a moderate-sized effusion. And it's not uncommon for us to be asked in our practice to aspirate joint effusions. And what scenario would that be in? Typically in 2 or 3 scenarios. Sometimes the question is, does the patient have crystalline disease of some kind? Could we please tap the joint? Sometimes the question is, are we dealing with a septic joint? And we'll be asked to evaluate the knee if there's fluid to tap it. And then we have a big, very big joint replacement service, and replace joints that the orthopedic joint surgeon suspects may be infected. Well, it's not uncommon for us to be asked to scan the knee, and if there's any sign of fluid, to tap it and send it for laboratory analysis. So here's a patient in whom we're aspirating the knee joint, and let's get our orientation. So this is a longitudinal or sagittal view. Here's the superior pole of the patella. Here's the quadriceps tendon. Here's the distal femoral cortex longitudinally. Here's the prefemoral fat. And notice these curved arrows. We have a complex effusion in the suprapatellar bursa. Here's our needle coming in, and there's various ways to tap the knee. You can go on the medial or lateral sides at the margins of the quadriceps. I frequently go straight in the midline, just straight through the quadriceps tendon, and that's what I've done in this case. And here's the tip of our needle. You can see a little bit of hypoechogenicity and demarcating the margin. And then notice also there's this hyperechoic line here, and a little bit of shadowing or reflection rather coming off it. And this is actually local anaesthetic that tracked along the superior margin here. There may be even 1 or 2 tiny bubbles of air in it, and that's our local anaesthetic. So it's not uncommon for, in our practice, to be asked to aspirate a knee joint effusion. And then here's a more complex, here's an extended field of view. Here's the patella, tibial tuberosity, the quadriceps and patella tendon. And here's a more complex, large effusion in the knee joint. Here's the anterior femoral margin. Another patient, you can see that this is longitudinal, this is transverse. Here's the distal femoral cortex, here's the patella. And you can see that this fluid is not, it doesn't look like that really hypoechoic fluid that we looked at a few slides earlier. This has a lot of echoes in it, In terms of evaluating fluid, remember that in the setting of infection, that whether fluid is infected or not cannot be determined by ultrasound criteria. So, I mean, this looks like it's complex. Is this infected? It could be. On the other hand, that very hypoechoic fluid could also be infected. So you can't look at the fluid and decide because it's hypoechoic, it's infected or it's not infected. If there's a question, is the knee joint infected, then it requires aspiration and laboratory analysis. If we go on, this is a joint body in the suprapatellar bursa. This is an ossific body from which is formed because the patient has arthritis. You can see some shadowing. And this is pannus, this is synovium, and there's fluid we see in the suprapatellar bursa, but there's also the synovium or pannus in the patient with rheumatoid arthritis. All right, so let's go on now. So we've looked at fluid. Let's go on. There's 3 bursa in the anterior knee, so let's go on and we'll have a look at those bursa. So the first one is the prepatellar bursa, which sits just on the anterior aspect of the knee joint, and usually we don't see it unless it's distended. Here's the patella. This is a long axis view or longitudinal view, sagittal view. This is a short axis view, and here's complex fluid in the prepatellar bursa. And what is the cause of bursitis? Well, bursitis itself is kind of a ragbag term. Things that we see causing bursitis can sometimes be traumatic with a heme bursa in the prepatellar bursa. It may be sometimes infection, and then it may be crystalline disease, in particular gout can affect the prepatellar bursa. Here's another patient, prepatellar bursitis. This time the bursa is more distended, looks very complex. So here's the bursa sitting on top of the patella. And then here's a longitudinal view, and you can see it tracks up. This bursa is so big it tracks up over the quadriceps tendon. So I apologise for the spelling mistake on that previous slide. So now, if we look at the infrapatellar bursa, there's a superficial and deep infrapatellar bursa. And so we bring the probe down over the distal patellar tendon adjacent to the tibial tuberosity. And then this is superficial infrapatellar bursa. Here we see quite a large collection of pretty much uniformly hypoechoic fluid tracking up over the patellar tendon, coming down to the tibial tuberosity. And then we just come a little bit higher for the deep infrapatellar bursa. We're in the same area. And here's fluid in the deep infrapatellar bursa. Occasionally you'll see a trace of fluid in the deep infrapatellar bursa normally, but you shouldn't see fluid like this. All right, so we'll look at some anatomy on the lateral side of the knee. And let's go, we've got the iliotibial band. We'll start on the iliotibial band. So there's 3 or 4 structures that are very important. The iliotibial band, then we have the popliteus tendon coming in, the fibular collateral ligament and the biceps forming to insert on the lateral aspect of the head of the fibula, and then behind we have the common peroneal nerve. So the iliotibial band is the most anterior, and it runs down. There's an extension of the fascia lata in the thigh. It runs down. This is a longitudinal image, and you can see it outlined by the arrows, and it's going to insert on this structure here, which is called Gerdy's tubercle, which is a tubercle on the anterolateral aspect of the proximal tibia. Here we can see there's a little bit of the anterolateral lateral meniscus in the image. So that's the iliotibial band. This is iliotibial band syndrome, which we typically see in runners. This slide was kindly loaned to me by David Fessel. And the iliotibial band tends to get a little bit swollen, a little bit irregular. You often form a bursa in this region, and when you scan, the patient has tenderness in this area, and what happens is the iliotibial band tends to rub on the margin of the lateral femoral condyle. So this is iliotibial band syndrome. And then we come a little bit more posterior, and this is it's really a coned down coronal image, but this structure here is the notch for the popliteus. We can see the notch for the popliteus on a radiograph, and here's the popliteus tendon, which is going to insert into the notch. So that's the popliteus tendon. And then there's the fibular collateral ligament proper, the cord-like fibular collateral ligament, which is going to arise just above the notch for the popliteus and run backwards and downwards slightly to insert with the biceps on the lateral aspect of the fibular head. And the fibular collateral ligament can actually be quite tricky, can be difficult sometimes to visualize. And you can see here's another coronal cone down image. Here's the notch for the popliteus. Here's the fibular collateral ligament arising just above the notch for the popliteus. It's going to come down, and then as you come halfway down or 2/3, you often lose it from anisotrophy, and sometimes you just can't seem to get it in the plane the way you want it. And then we kind of rearrange reposition the transducer, and here's the notch, right, for the popliteus, the popliteus tendon just sneaking in the corner here, and then here's the distal fibular collateral ligament inserting on the lateral aspect of the fibular head. And then immediately adjacent to it, but coming in the opposite way, is the biceps femoris tendon. So we're going to angle the transducer in the coronal plane along the long axis of the distal biceps femoris tendon. And the biceps femoris is actually quite a large tendon inserting on the fibula. We can see it here. I'll show you this image here though. This is a better view. Here's the fibula. This is a longitudinal or a coronal, cone down coronal image, but but here's the distal biceps that fans out. It's pretty much uniformly hyperechoic. And then if we come even more posterior on the lateral side of the knee, we run into this structure here, the common peroneal nerve, which typically the sciatic nerve bifurcates the posterior tibial and the common peroneal. It bifurcates around the region of the top of the popliteus, popliteal fossa rather. Although it's variable, the bifurcation can be variable. Sometimes it's higher in the thigh, but the common peroneal nerve runs down and then it runs around the neck of the fibula and divides into two structures, the superficial and deep portions of the common peroneal nerve. And here it is. Here it's cord-like. It's behind the biceps tendon. It's going to run down, and then it's going to run around the neck of the fibula. This is a longitudinal image. Here it is here, this cord-like common peroneal nerve. And then here it is in transverse. And we can see these little fascicles, which tells us that we're looking at the nerve, and it's it runs behind the biceps. And a couple of cases kindly loaned to me by David Fessel, a couple of clinical cases. Here's a schwannoma and the superficial peroneal nerve, and we can see that the nerve is quite elongated and oval looking here, and it's of mixed echogenicity with areas of increased vascularity. And here's a patient with an amputation, and here's a post-traumatic stump neuroma. Here's the common peroneal nerve, and here's the stump neuroma. All right, so let's go on the medial side of the knee now. And the medial collateral ligament is a very broad, thick structure which arises from the medial femoral condyle, starts at the medial femoral epicondyle, and then runs downwards, attaches to the tibia. And here it is on ultrasound examination. So this is like a coronal image that we've orientated. Here's the medial femoral condyle. Here's the medial tibia, and then this is the medial collateral ligament running downwards, correlating with the anatomic drawing. This is how we have our probe position to get this image. And then this is a more cone down image of the normal medial collateral ligament. And here's the distal medial femoral condyle. Here's the proximal medial tibia. And if we look at the medial collateral ligament, this is all medial collateral ligament, but it typically has superficial and deep components. And can you see this linear line here? This tiny little hypoechoic slit. That is the demarcation between the superficial and deep parts. That is histologically either fibrofatty tissue, or sometimes you actually can have a bursa sitting in here. And then the deep part is intimate with the medial femoral condyle and the tibia, and also is intimate with the outer part of the medial meniscus. Now most imaging for MCL tears we do with MR, but occasionally we get asked for one reason or another to look at the medial collateral ligament with ultrasound. And here's an acute medial collateral ligament tear. So this is a coronal image. Here's the femur, here's the tibia, and we don't see anything like we saw with that nice normal appearance of the medial collateral ligament. It's pretty much uniformly swollen, both on the femoral side and also the tibial side. So these appearances are consistent with an acute medial collateral ligament injury. And here's another case. So again, it's a cone down coronal image. Here's the medial femoral condyle. Here's the medial tibia. Here's the medial collateral ligament, but we don't see anything that looks like that normal appearance that we looked at 2 or 3 slides ago. This is all uniformly swollen, and on scanning these patients, it's very, very painful. Notice the tear goes down, and it's involving both the superficial and deep parts of the MCL. Here we see some of the body of the medial meniscus in the tear. And remember, the deep part of the medial collateral ligament is intimate, is directly attached to the body of the medial meniscus, and so the tear goes right down, involve both the superficial and deep parts. And then here's a corresponding MR, and we can see that we have bone bruise pattern on the lateral side of the knee. That corresponds with a valgus, what we call a valgus force, or a force coming in from lateral, with impaction laterally and opening out of the knee joint medially. And we can see that there's irregularity and swelling and fluid, a little bit of fluid involving the medial collateral ligament, particularly the deep portion. Frequently these cases will have an associated anterior cruciate ligament injury, and most of these cases we image with MR. But in this case, actually, it was a pure valgus force, and the anterior cruciate ligament was intact. And here's another case that's even more severe, acute MCL tear. In this patient, the medial collateral ligament is pretty much trashed. Involves both the femoral and the tibial portion, and there's a corresponding MR, and we can see that not only is it the ligament swollen and looks irregular, but it's also redundant. See, it's sitting there waving, looking back at us, and that's because it's been avulsed, or some of it's been avulsed distally. So that's like what we call a stage 3 MCL tear, which means the MCL is pretty much trashed. And here's a case of a chronic MCL tear, and sometimes with chronic MCL tear we get this calcification, or it's really usually, I think, actually ossification, which we call Pellegrini striata, calcification / ossification. You can see some of it here. It's a sign of previous medial collateral ligament injury. And here's the ossification on the radiograph, AP radiograph, and here it is on the ultrasound, and then here's the chronic change in the medial collateral ligament on this cone down coronal image on the medial side of the knee. Now, assessment of the posterior knee, we frequently get asked, is there a Baker's cyst? And so to image the posterior portion of the knee, we have the patient turn prone, and here's the positioning of the transducer for the Baker's cyst on the medial side of the knee. And there's these two structures which are very important, which we're going to look at. One's the medial head of the gastrocnemius, and the other one is the semimembranosus. And so they sit next to one another. Sometimes there's a bursa there, sometimes there's a Baker's cyst. In this case, there's no bursa and there's no Baker's cyst. This is normal. So medial head of gastrocnemius, semimembranosus. And then here's a patient, medial head of gastrocnemius, semimembranosus, and there's a little bit of fluid in there's a gastrocnemius semimembranosus bursa, which forms here. And so there's a little bit of fluid in the bursa, but there's not a frank Baker's cyst as yet. So I just want to make 1 or 2 points when we go and look at actual true Baker's cyst. So they're very common around the knee joint. And this point I want to make is, if you remember absolutely nothing else from this lecture, I feel it will be a success if you remember this point. If you diagnose a Baker's cyst, you must always, 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 always identify the neck. You cannot diagnose a Baker's cyst if you cannot find the neck. And why do I say that? It's because not all cystic masses behind the knee are Baker's cysts. And in particular, you can get ganglia forming there, you can get myxomatous tumours, but occasionally you can actually get sarcomas which can look very, very hypoechoic. The classic example is the synovial sarcoma. Some other sarcomas form a lot of myxoid tissue as part of the tumour. Another tumour that can do it is the lipoblastic sarcoma. So if you remember nothing else about this lecture and someone asks you to look at a Baker's cyst, remember that you must always identify the neck if you're going to call a cystic mass behind the knee a Baker's cyst. And if you can't identify the neck, if you're not certain it's a Baker's cyst, you have to work it up, you have to get an MR. All right, so remember we looked at the medial head of the gastrocnemius and the semimembranosus sitting next to one another, and then we looked at a little bursa forming, but this is clearly a Baker's cyst here, right? So here's this large rounded hypoechoic or predominantly hypoechoic structure, and here's the neck, right, between the semimembranosus and the medial head of the gastrocnemius. Here's the neck, so we feel comfortable this is a Baker's cyst. And then here's the long axis view. So the neck is identified in the short axis view. Here's the long axis view, Baker's cyst, which typically will track out between the medial head of the gastrocnemius and the adjacent subcutaneous tissue, and this cyst has a nice inferior rounded margin on this slightly extended field of view longitudinal image. And then here's another one. Remember, we have to identify the neck on the axials, right? Here's another one, rounded inferior margin. So this is Baker's cyst sitting on top of the medial head of the gastrocnemius. The cyst is between the medial head of the gastrocnemius and the adjacent subcutaneous tissue. And then here's another one. Here's the neck on the axial, it's slightly complex, and it's got a slightly irregular tail or margin, and this we frequently see when the cyst starts to rupture or has ruptured. And then here's one which actually I'm talking on tomorrow. I'm talking on fusion of ultrasound with CT and MR data. But here's one that we did a case where there's fusion with MR. Here's a Baker's cyst with septation, slightly complex, long axis view corresponding MR in exactly the same plane and same position. And here's a ruptured Baker's cyst, right? And so this doesn't, and we know this has to be ruptured, right? Remember, we've identified the neck, we feel comfortable it's a Baker's cyst, and doesn't look at all like those earlier ones we looked at. It's somewhat elongated, it's got this very irregular inferior margin, which we call the rat's tail sign. So that's a ruptured Baker's cyst, and remember they can be very painful for patients. And here's the corresponding MR on this patient with the, here's the coronal MR, here's the Baker's cyst, here's a lot of edema and soft tissue irregularity inferiorly at the tail. So that's a ruptured Baker's cyst. And then occasionally a Baker's cyst will occasionally get patients that are difficult and that the cyst, instead of rupturing where it should, between the medial, over the top of, or adjacent to the medial head of the gastrocnemius and the adjacent subcutaneous tissue, what happens is it ruptures between the medial head of the gastrocnemius and the soleus, and they can be difficult clinically, and sometimes they can be difficult radiologically as well. And the classic condition that this is associated with is rheumatoid arthritis, although this patient didn't have rheumatoid arthritis. But here we can see this complex fluid collection between the medial head of the gastrocnemius and the adjacent soleus. And actually in this patient, we thought there was probably a neck, but we weren't certain, and we wanted to make sure we weren't looking at something else. And here it is on MR. Here's the medial head of the gastrocnemius, here's the soleus, here's this lobulated collection. And I won't show you the MR image, but when we went higher up, we could track this, this collection to a neck. And then, sorry, I think there was a spelling mistake on that previous slide as well. I apologise. Here's another case, ruptured dissecting complex Baker's cyst, and this one has actually followed the rules and is sitting on top or adjacent to the medial head of the gastrocnemius and the adjacent subcutaneous tissue. Notice how it's elongated, it's got a very irregular margin, it's got complex fluid within it. Now, here's another case. So I just want to reiterate this, this last point before we come to the final slide. But this looks like it should be a ruptured Baker's cyst as well, right? And it's got a somewhat irregular margin inferiorly. It looks like it should be a Baker's cyst. The thing is, we couldn't find a neck. And this turned out to be a ganglion. We actually ended up aspirating. But the point I want to make, it's, as I say, if you remember nothing else, if you're going to call a Baker's cyst behind the knee, you must identify the neck. If you cannot identify the neck, you can't say for certainty it's a Baker's cyst, and it may be some other cystic mass. And we don't want to miss something nasty. So, in conclusion, we think ultrasound's useful, fast, and it's an inexpensive modality for answering specific clinical questions. So we're not saying, you know, all cases that are done with MR should be done with ultrasound or vice versa. But there are certain clinical scenarios where it's very helpful. We've found it most useful in 4 settings: evaluation of the quadriceps tendon rupture, evaluation of patella tendon rupture, evaluation of an effusion, and evaluation of Baker's cyst. Thank you. So I usually roll up a towel, small towel, and just put it under the patient's knee just to make the knee a little bit more comfortable. I think it helps if you have the knee in a tiny bit of flexion as well. So the patient should be nice and relaxed, and hopefully the examiner should be nice and relaxed as well. And I start off in the midline, anteriorly, and so let's see what we can identify here now. We've got an arrow.
It's always going to be this side.
Yeah, no, that's fine. I just an arrow to point with on the screen.
Sorry, point it right there.
Okay, so if you can see my hand, we're in the longitudinal or sagittal plane. Here's the patient's patella, which we can both see and is easily palpable. So I'm just above the patella, and what's the anatomy we have here? Well, this hyperechoic line is the anterior distal femoral cortex. Just anterior to that is the packing fat or the prefemoral fat over the distal femur, and then there's basically minimal fluid in this patient's knee joint. This structure, triangular structure here, is some of the suprapatellar fat pad. There's a tiny little hypoechoic slit here, which is a tiny bit of fluid in the suprapatellar bursa, but there's very little fluid in this patient's knee joint. And then immediately above here, this hyperechoic or bright, if you like, fibrillar structure is the quadriceps tendon inserting onto the superior pole of the patella. So that's longitudinal. So let's just patella tendon, quadriceps tendon, anterior distal femoral cortex, prefemoral fat or packing fat, if you like, over the distal femur, suprapatellar fat pad, really minimal to no fluid in this patient's knee joint. A tiny bit of fluid, it's a little bit of fluid actually, if we come at the lateral margin of the knee. See it? So that's normal. Come over on the medial side, a little bit of fluid on the medial side. So that's normal. All right, so we turn at right angles. now I have the transducer in the transverse plane. What's the anatomy we're looking at now? All right, so this is this bright line. It's the brightest line that we can see. That's the anterior distal femoral cortex. And then immediately adjacent to the anterior femoral cortex anteriorly is the packing fat or the prefemoral fat over the distal femur. And then, let's see if I just relax a little bit, there's a tiny bit of fluid we can see in the suprapatellar bursa, and then above here, this oval hyperechoic structure looking back at us is the quadriceps tendon. We can follow it up to the muscular tendinous junction and follow it back down to the superior pole of the patella. And then, see if we can see. Not much fluid in the knee joint. See a tiny, see this is the suprapatellar bursa. I don't press very harshly. We can just see there's a trace of fluid. All right, so here's the patella. All right, so let's just move inferiorly. We'll start off on the longitudinal plane. All right, so what's our anatomy? So here's the inferior pole of the patella, right? And then here's the tibial tuberosity. We're in the longitudinal plane. Here, see this nice fibrillar hyperechoic structure? It's this width. This is the patellar tendon, right? It's going to run from the inferior pole of the patella downwards to insert on the tibial tuberosity. And then immediately deep to that is Hoffa's fat pad, that extensive prominent fat pad over the anterior knee joint. And then we can just see sneaking in here, this is some of the subchondral bone plate of the femoral condyle with the adjacent, see this hypoechoic area, that's actually hyaline cartilage. All right, so that's longitudinal patellar tendon. And it jumps out, right? It's not particularly difficult to find. If we turn transversely, inferior patella, inferior pole here of the patella, and then here's the patellar tendon, and transverse taking off. It's going to run down. We can see it. Here's behind it is Hoffa's fat pad. It's going to come down, see it, come down, 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 and then it's going to insert on the tibial tuberosity. So the quadriceps tendon and the patellar tendon are not hard to find. Notice also we get on this view, for free, we get a quick look at the trochlear notch and medial and lateral femoral condyles, and then subchondral bone plate, and then some of the hyaline cartilage, the trochlear notch. All right, so quadriceps tendon and patellar tendon aren't difficult to find. All right, I'll just turn your knee a little bit. Let's have a look on the lateral side of the knee. So, remember we went over the anatomy. I wonder if we can we just blow this up a little bit? Yep. Okay, good. So let's get orientated. Right, this is distal femur here, distal femoral condyle. Here's proximal tibia anteriorly. And now we've got this structure. This structure here, see it? This linear structure comes down and inserts on this tubercle we call Gerdy's tubercle. This is the iliotibial band, and we can follow it more proximally. See, this is iliotibial band, and this is where we get iliotibial band syndrome. This is where classically in runners the iliotibial band will rub against the lateral femoral condyle. Remember, we looked at that case that David Fessel kindly loaned me from the University of Michigan So here's the iliotibial band. And notice, let me see if I can show it a little bit better. There's a little bit of the anterior horn of the lateral meniscus sneaking in there, in here, looking back at us, although we can't see it that well. All right, so good. Okay. So let's see if we can find the popliteus tendon. And here's the structure here, the notch for the popliteus. Which you can see on a radiograph, obviously, on the lateral aspect of the knee. So here's the notch of the popliteus. And here's the popliteus tendon. That's better. Just a question of reorientating. So here's the notch of the popliteus. See the notch in the lateral femoral condyle. Here's the popliteus tendon, which typically we don't get asked to look at clinically, but is sitting here looking straight back at us if we go looking for it. And then immediately above the notch for the popliteus is the origin of the fibular collateral ligament, the cord-like fibular collateral ligament. Which is going to run, which is, I think, if you remember what I said, could be difficult sometimes. So here's a notch for the popliteus, and then the fibular collateral ligament is going to take origin just above the notch for the popliteus, and it's going to run downwards and then downwards to insert with the biceps on the fibula. So let's just get the come more posteriorly. All right, so here's the lateral portion of the head of the fibula, and then here's the distal biceps tendon. Going to come in and insert on the lateral portion of the head of the fibula. And then if we just reorientate, here actually we see some of the body of the lateral meniscus. So let's just reorientate, and then here is the origin of the fibular collateral ligament. It's going to run downwards and forwards. It's often hard to get on one cut. To insert, it's going to join most typically with the biceps. In fact, you can see it here, and then insert as the conjoint tendon on the lateral portion of the head of the fibula. Okay, and then, oops. We come a little bit more posteriorly. We're going to run into this structure, this cord-like structure running downwards, and this is the common peroneal nerve. It's going to run downwards and then it's going to wind around the neck of the fibula. So here it is here. It's going to come down, 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 down. And then it's going to run around the neck of the fibula. So here it is in transverse. And here it is in longitudinal. Here it is in longitudinal. Okay, all right, let's have a look on the medial side of the knee. And we can see that this patient has got a pretty photogenic looking medial side of the knee. Okay, so let's get orientated. Here's the medial femoral condyle. Here's the medial tibial condyle. This is actually between the two, in the joint space here, this is body of the medial meniscus, which you can see here sitting back looking at us. And then this is all medial collateral ligament. Now, sometimes you don't, let's just see if we can find that. See, I think, here we go. See, there's a tiny little hypoechoic slit. I don't know if you can appreciate that. See, there's a tiny little hypoechoic slit here. And that's that demarcation between the superficial and deep portions of the medial collateral ligament. It's typically fibrofatty tissue, but as I mentioned in the talk, sometimes you can actually have a bursa forming here. Now, in the setting of medial collateral ligament injury, which in most cases we'll get asked to do an MR, and that's fine, but occasionally you'll have a patient that for whatever reason they can't go on an MR, or there's some other problem, or it's not certain on the MR whether there is truly a medial collateral ligament injury. We'll image the medial collateral ligament on ultrasound, and if there's any significant injury to the medial collateral ligament, it will be very painful. And that's one of the advantages of doing ultrasound, that you actually see and talk to the patient and know whether they're symptomatic.
17, if you'd like to use that too.
Yeah, we might try that. What else was I going? See, and actually, look, you can see the body of the medial meniscus here. Now, we do see the menisci when we're examining on ultrasound, but I wouldn't recommend you use it as a tool for diagnosing meniscal tears. Occasionally you'll see an obvious meniscal tear, incidentally, on ultrasound, but really evaluation of the menisci is best left to MR. Let's try that. Can we try that? See if we can cone down, or see if we can get a better definition of those two layers of the MCL. So here we're coned down. Now let's have a look. Yeah, that's good. Can we have that arrow back? So if we look, right, look, here's medial femoral condyle. Look at my probe. It's basically a coronal image, right? Here's medial tibial condyle. Here's body of the medial meniscus. This is all, actually we see it beautifully. This is all medial collateral ligament. Now, I think, well, I'm not, there's a little hypoechoic cleft here, but I think that's too superficial. There's the other suggestion, there's a little hypoechoic cleft here. Sometimes you cannot find that cleft between the two layers. See, there's a suggestion there's a cleft in here. I'm not sure whether that's actually truly the demarcation or not. But this is all medial collateral ligament injury. If we, pretended that it had been injured in this patient, it would be swollen, it would be slightly irregular, hypoechoic, and it would be quite tender for us to examine the patient. Okay, should we have a look at the back of the knee and then we'll finish? So to look at the back of the knee, you really want to ask the patient to turn prone, and then the other thing which you want to be aware of is sometimes you'll start to scan the wrong knee. I've done that. Okay, so let's have a look at the anatomy. So, see my probe, it's similar to remember those diagrams we looked at in the talk? So it's transverse, right? So, and this is like, I don't mean to keep going on about this, but it's probably the most important part of my talk about you must identify the neck of a Baker cyst. So let's just look at the, see here we've got medial femoral condyle, this is subchondral bone plate. This is actually, see this area on top that's hypoechoic, that's actually hyaline cartilage. And then this is the medial head of the gastrocnemius here, and here's the semimembranosus. So this is where the neck would be. And this is where this gastrocnemius semimembranosus bursa forms, and this is where the neck would be. Then if the patient had a Baker cyst, most typically it would come out and track on the medial aspect of the calf between the medial head of the gastrocnemius and the adjacent subcutaneous tissue. So that would be this would be the position. This is the most common site to find a Baker cyst, and then a longitudinal. Remember those images we looked at, we'd expect to see it coming out, sitting on the medial head of the gastrocnemius between the medial head and the adjacent posterior subcutaneous tissues. Remember, occasionally they can, as in that case I showed, it'll track between the medial head of the gastrocnemius and the soleus, and they can be difficult. So this is where you want to look for the neck of the Baker's cyst. Here we just get a sneak preview. Here's a neurovascular bundle. Here we can see the popliteal artery pulsing away, and then we come over on the lateral side. This is the subchondral bone plate of the back of the lateral femoral condyle, and actually notice this hypoechoic 3 millimeter, 4 millimeter area on top of it. That's actually hyaline cartilage. And notice actually also that the width of the hyaline cartilage is not uniform, and that's normal. Cartilage is not uniform in the knee, and actually here we see, here's the common peroneal nerve, and actually here's the posterior tibial nerve, and then here's the common peroneal nerve that's going to come down. Going to come down and then come down, and then it's going to run, here it is here, it's going to run around the neck of the fibula and then disappear. Okay.